Trace the space. Going back to basics. We assure we have no financial interest in this video. So here is a case of a 21-year-old female patient with history of barrage laser and 2 sittings of cryo in right eye and barrage laser in left eye. She presented with decreased vision in right eye for past 3 days. On examination, her right eye had best corrected visual acuity of 5/60, anterior segment normal, fundus examination showing subtotal pigmentogenous retinal detachment with macula off in phakic eye with no PVD or PVR changes with barrage laser scars. Her left eye had best corrected visual acuity of 6/6, normal anterior segment, fundus examination showing status post barrage laser, stable retina. Patient was planned for right eye pars plana vitrectomy, endolaser, fluid air exchange and tamponade. After subtenance anesthesia, 3 25 gauge ports were placed. After checking intravitreal placement of port, vitrectomy was performed. Lattice with hole noted at superiotemporal quadrant with barrage lattice inferiorly with cryo scars. Subtotal RRD with macula off was noted. After performing vitrectomy and clearing around the break, fluid air exchange was performed. Suddenly, we noticed a donut-shaped air entrapment behind the lens. After confirming that the infusion was still intravitreal in position and confirming that there is no subretinal slippage of infusion cannula, the procedure was continued. Continuation of fluid air exchange resulted in subretinal air migration. Let's have a quick recap of how air migrates into subretinal space. So what went wrong in this case? Let's take a deeper look into anatomy. Crystalline lens is in contact with vitreous and is attached to it in a circular fashion with hyaloidocapsular ligament, also known as Weger's ligament. There is a potential space between hyaloid phase of vitreous and lens capsule in a circular fashion known as retrolental space or Berger's space. But what's more important is there are 2 other important spaces which we need to look into carefully. This image shows canal of Hanover. There is a space between pre-equatorial and post-equatorial zonules, and canal of Petit, which is a space between post-equatorial zonule and hyaloid zonule. This space is continuous around and is bordered by lens capsule centrally and pars plana and plicata peripherally. This is also known as Garnier space. Normally, when ports are placed 3.5 to 4 mm from limbus based on the lens status, it's placed into the intravitreal cavity. So what went wrong in this case is, though the infusion was inside vitreous cavity, the vitreous around the infusion may be intact or there may be anterior slant of the infusion resulting in forcing of air to percolate through the Garnier space, resulting in opening of break, which in turn resulted in subretinal air as the retina is thinned out post-cryo. This case was managed by clearing vitreous around the infusion area, making retinotomy and suctioning the subretinal air, followed by fluid air exchange, endolaser and silicone oil injection. So, what all can possibly go wrong when we don't understand this importance of proper placement of sclerotomy ports? Normally, the sclerotomy has to be placed parallel to the limbus, 3.5 mm from limbus in pseudophakics and 4 mm from limbus in phakics. With advent of 23 and 25 gauge cannulas, an oblique wound construction has reduced incidence of hypotony and wound leakage. When the port is tilted posteriorly, and there is subretinal slippage of infusion, it can result in retinal detachment. This needs replacing the infusion and repositioning of the scleral port and drainage of subretinal fluid. When the port is tilted anteriorly, it results in air entrapment tracking through the Garnier space, further migrating into anterior chamber through the zonules. This can result in deepening of the anterior chamber and posterior displacement of the iris lens diaphragm. The infusion of air into anterior chamber evolves quite rapidly as soon as fluid-air exchange is started. In most cases, this necessitates resumption of fluid infusion, removal of air from anterior chamber, repositioning of infusion cannula. This can be avoided by perpendicular orientation of cannula before fluid-air exchange. This is a video clip showing fluid misdirection into AC, resulting in deepening of the anterior chamber, posterior bowing of the iris lens diaphragm, which has resulted in lens touch due to posterior lens displacement. A study conducted by Ryan et al. To review the incidence of possible mechanism of infusion misdirection included 232 eyes. This case series included 16% showing episodic hypotony due to infusion blockage, 3% showing inadvertent airflow into the anterior chamber. Another study by Robert L. et al. Showed previtreous space gas sequestration during pneumatic retinopexy. He concluded proper treatment requires prompt recognition of the trapped gas and removal via needle aspiration. New gas can then be injected after deeper insertion of the needle into the central vitreous cavity, preferably under direct observation. If unrecognized, the gas bubble trapped in this space could expand, creating retinal dialysis, lens dislocation, or cataract. This is a picture showing donut-shaped air sequestration behind the lens, which is noted due to entrapment of air in the Garnier space. So, how do we avoid this? Precautions to be taken include avoiding anterior positioning of the trocar, avoiding too much anterior slant of the trocar, avoiding longer tunnel for trocar placement, vitrectomy around the trocar opening. The eye cannot see what the mind does not know. These are my references. Thank you.